Okay, guys, this is your second review for maternity, and some topics that are going to be included on this week's exam will be pregnancy, so the pregnancy period, the antenatal antepartum period, which is like that period before delivery, right? Those, you might hear those terms, they're kind of interchangeable. They essentially just mean the same thing. The fetal heart rate monitoring will also be on this exam. The labor and delivery period will also be on this exam, and then there may be some questions on your weekly articles, so just make sure that you read them. Okay, so pregnancy and the antenatal antepartum period. Pregnancy education. So you want to inform your moms who are even thinking about becoming pregnant to be sure to start taking prenatal vitamins, specifically the folic acid. So even if, you have a mom that's like, well, I'm not regularly like using any specific like pharmaceutical birth control, but they're using other methods because, right, there's different methods of preventing pregnancy. If they are not specifically on some form of birth control using condoms, they should be taking folic acid, even if they're not technically trying to get pregnant. Do you guys know why folic acid is so important? You can feel free to type it into the chat. I know one of you
Prevent
knows.
neuro deficit.
Yeah, neural tube defects, such as like spina bifida. So it's super, super important to educate them to take that folic acid in particular. You also want to teach them about torches and teratogens. So these are risks for in utero infections, deformities, and possibly stillbirth. One of them is toxoplasmosis. So it actually is like, it goes in order of like torches, stands for, each letter stands for a possible risk to the fetus in utero. T is for toxoplasmosis. This could happen if the mom or the parents have an indoor cat. That toxoplasmosis can cross the placental barrier and harm the fetus. Other diseases include syphilis, GBS, varicella zoster. Rubella and Rogam, we talked about that previously, so you guys are well informed about that. Cytomegalovirus is another one, and then also herpes simplex virus 2. Alcohol and smoking are probably the two biggest like teratogens we need to do patient education on, right? There has been, this thought people have had that, once they're past a certain trimester or they're in their third trimester, they may ask you, is it okay for me to have like a glass of wine? There is no solid evidence that shows that that is okay. And actually, there's newer evidence showing that there is no way of telling what amount of alcohol, that like any amount of alcohol could potentially be a risk and harmful to the fetus. So we want to educate them that like to pretty much abstain from alcohol and smoking as well. Pregnancy education continues. So we want to make sure we're educating them on weight gain is a normal thing that happens during pregnancy, right? It's an expected part of the process. This is particularly important to address with moms that may have had eating disorders or body dysmorphic disorder. If they have a history of that, it's super important to make sure that they have the right support because that could be highly dangerous for the fetus and the pregnancy. We want to inform them that a healthy weight gain is not too much, not too little, right? We don't want them taking in too many calories because that could lead to gestational diabetes and macrosomia. So that first trimester, they're going to gain the least amount. They'll gain between 1 and 4.5 pounds in total. During the second trimester, they'll gain 1 to 2 pounds per week. The third trimester, they'll gain 1 to 2+ pounds per week. This is the most that they're going to gain during their pregnancy. They're going to like pretty much blow up towards the end, right? And let me know if I'm going too fast for you guys. Preparation for labor. You want to teach mom the benefits of Kegel exercises and strengthening that pelvic floor, specifically the muscles of the pelvic floor. This is going to aid in their ability to have a decent labor. If they are GBS positive, we will be doing IV antibiotics from the time that they start their labor until baby is delivered. This protects baby from neonatal sepsis. If they have a sedentary lifestyle or they travel frequently, we want to be informing mom, just try to get up, walk around as much as possible. Frequently is what you would tell them. Get up and walk around frequently. That's important. For vaccinations, as you may recall, for MMR, they're going to get that right after that first pregnancy. If baby ends up being positive and mom is negative, we have to give that RhoGAM shot. They want to have an MMR at least 1 month prior to pregnancy to prevent from birth defects. During pregnancy, we inform moms to be getting the Tdap and if it is flu season, the inactivated flu vaccine should be given both during pregnancy. Okay, so for the placenta, this organ is developed by the 12th week of gestation. It provides maternal fetal exchange of, do we have a question?
Yeah, I was just hoping if you could go back to the other
Yeah,
slide
of
for like maybe
course.
10 seconds.
Yeah, of course.
Okay, inactivated flu during the flu season. Okay, thank you so much.
Mm-hmm. So for that maternal fetal exchange, we have an exchange of oxygen, nutrients, baby's waste products are being excreted through the placenta as well. During labor, when there's contractions, these spinal arteries are going to be getting compressed. This leads to a decrease in all of these exchanges. So during if there is a prolonged labor, there's going to be less and less of those exchanges between mom and baby, right? That's why it becomes a problem if there are those late decels. Early functions of the placenta, it acts as an endocrine gland. That's important to know. Hormones. The hormones that the placenta helps regulate are the human, I'm going to butcher this, chorionic gonadotropin, HCG. This is the hormone that indicates the positive pregnancy test. It is also the hormone that's a contributing factor to that nausea, vomiting that moms may get in the early parts of their pregnancy. And then I believe that there is a condition too that may last through. I had a friend that actually, she had this condition where she was basically violently ill the entire time she was pregnant, and I believe it's in regards to this hormone. The placenta also regulates estrogen, progesterone up until the time of delivery, right? And then also human placental lactogen. So this is responsible for the nutrients as well. Changes with pregnancy. So we have hemodynamic and hematologic changes. So during pregnancy, there is an increase in blood volume, that's hemodilution, that may lead to anemia. This causes a decline in hematocrit and hemoglobin. So if the baseline is already low for mom in these labs, it is important that we do some patient education on mom increasing dietary iron so that doesn't become a super big problem with anemia. Supine hypotensive syndrome. So this is going to happen towards the end of the pregnancy or during the laboring process. You might see this happening. Basically, it is the inferior vena cava is becoming compressed when mom is lying on her back. What we would do is we would reposition mom to her side and then reassess blood pressure. For renal, there's going to be an increase of plasma blood flow to the kidneys. For the uterus and cervix, the uterus increases in size about 15 to 20% during pregnancy. Cervix, we have the mucus plug starting in the beginning, right? That softening and ripening of the cervix with implantation. It's going to seal off the uterus and protects from any infection. We have Goodell's sign, which is an early indication of pregnancy. This is that softening of the vagina, cervix area, and increased vascularization. And then for the vagina, we might be able to observe and inspect Chadwick's sign, which is the mucosal color changes of the vagina cervix, and it is like a bluish, purplish color change that you see, and that's just that increased vascularization to that area. Guys good on this one?
Do you mind going back for a couple more seconds?
Yes, of course. I know that there's a lot, like try not to like write down every single word for word. Try to just be taking notes and listening to what I'm hitting on. But I know it's kind of a lot, so I'm happy to slow down. Just let me know.
Okay, all
Good?
good. Thank you.
Great. Okay, pregnancy and domestic violence. So mandated reporting is part of the professional nurse role. It is always your priority to be addressing this. So if there is any suspected and or witnessed abuse, if there's witnessed, you're going to contact security right away. If there is suspected or witnessed, you're also going to be contacting the social worker to file a report. Okay, Nagel's rule. So the way I do Nagel's rule in my head is I take the first day of the last menstrual cycle, and then I add a year, and then I add 3 days, and then I subtract 3 months. That's just PEMDAS like ingrained in my mind. But this is also a great little visual over here of how you would take the month, day, year, and you would subtract, add, and then you would get the estimated delivery date, right? I thought that was a cute little visual that might be helpful for some of you. Okay, so signs of pregnancy, there's presumptive signs, probable signs, and positive signs. So I think I'm pregnant or I feel pregnant. This is a presumptive sign. So tender breasts, intuition, those are presumptive signs. A positive pregnancy test is a probable sign. It is not confirmed yet because there can be false positive tests, right? With those pregnancy tests, sometimes they can get false positives. So that's why it is considered a probable sign. It is not a probable sign until you hear those fetal heart tones, right? Those are definitive positive signs that yes, you are pregnant. Okay, pregnancy duration, and this is my beautiful cousin here. She delivered in January, and she is fully cooked here too, just to gauge, what it looks like at how many weeks. She's about 40 weeks here. Delivered prior to 20 weeks is considered a spontaneous abortion. Born between 20 to 36.6 weeks is preterm. 37 to 38.6 weeks is early term. 39 to 40.6 weeks is full term. 41 to 41.6 late. And then 42 is post term. We do not want them to get anywhere close to like being late these days. I was 2 weeks late, so I was that post-term baby, but they won't even do that anymore from my knowledge. They will be getting you in and doing induction pretty much like a couple days after your due date. They don't want you going any longer. You're starting to get that placental insufficiency, and bigger problems could arise. Okay, Gravida versus parity. So Gravida is the number of pregnancies regardless of outcome. Parity is the number of pregnancies that have reached at least 20 weeks and have resulted in the birth of a fetus or a baby. Prima gravida is pregnant for the first time. Multigravida is 2+ pregnancies. Nulla gravida, they've never been pregnant. Nulla para reaches at least 20 weeks gestation and is pregnant for the first time. Prima para is completed pregnancy with a minimum of 20 weeks, either living or stillborn. Multipara is completed 20+, or sorry, not 20, 2+ pregnancies with a minimum of 20 weeks, either living or a stillborn. GTPAL, how we calculate this, we look at the number of pregnancies regardless of outcome for Gravida. We look at the number of pregnancies that have reached 37+ weeks for term. We look at the number of pregnancies that have reached between 20 to 36.6 weeks for preterm. And then abortion is the number of losses prior to 20 weeks. And then living is, however, the number of living offspring that they currently have. Okay, is it time? True versus false labor. So true is regular contractions, 5 minutes apart and lasting 1 minute for at least 1 hour. They're also likely unable to walk around at this point. The cervix will also be effaced and dilating with true labor. If the membranes rupture, you want to be making sure that you're giving regular temperature checks and you're checking that fetal heart rate regularly. This is a priority for this. There's infection risks for baby being compromised at this point. So those are priorities. False labor, by contrast, is Braxton Hicks. That's what it's termed. These are irregular contractions. They're typically relieved once mom starts walking around. So that's something you want to ask her, do they start to decline in the pain that you're feeling once you start walking around? That's going to be Braxton Hicks. If they do not have true labor, they've come in thinking that they're in labor, they're going to be discharged back home until the onset of true labor. If they're having a hard time and trouble managing their pain, you're going to recommend to them a warm bath or shower to ease the pain. That can also be recommended if they haven't reached this point of those regular contractions 5 minutes apart. If they're, longer period of time apart, even if they are starting to be regular, they may need to be told, like, wait at home when they're at that 5 minutes apart, lasting a whole minute for at least an hour, then it's time. That warm bath and shower to ease the pain is really helpful to let them know. Okay, labor, delivery, and fetal heart rate monitoring.
Ooh, sorry, just
Yeah.
yeah, if you could go back for just a second.
No problem.
Just wanted to get that checking the temp. Oh, and the fetal heart rate monitor. Okay, thank you so much.
No problem. Okay, labor, delivery, and fetal heart rate monitoring. Okay, for labor, we monitor them with the toco and ultrasound. This monitors the frequency and duration of the contractions. This does not monitor the intensity of their contractions. If that is something that needs to be known, whether they're having super prolonged labor, they're there for days and they're high risk mom, maybe they've had preeclampsia or something that they need extra support, extra, measures of monitoring. They may have an intrauterine pressure catheter. This will measure the strength of the contractions. Their water does need to be broken to have this inserted. It's an internal device. This is put in by a physician. There are risks of infection with this, so just monitoring mom frequently for temperature checks is important, and be keeping an eye on that monitor for fetal heart rate monitoring. Pain management. So they may opt to receive an epidural or they may not. If they do not and they're trying for, you know, a natural delivery, there's some non-pharmacological interventions that can be done. Music, massage. If one method stops working with that, what would you do? Say
Offer
that.
another method.
Yeah, exactly. Good job. Yeah, if something stops working, try something else. Totally. There is also nitrous oxide with narcotics, which I think would be amazing and I would totally opt for myself. However, it's not used everywhere, so there's that. Okay, induction. So Pitocin may be used for induction of labor, but it is also used for augmentation of labor, so changing the status of the labor or decreasing bleeding after labor. It may also be used for an abortion, but those two are important to know. Excuse me. Pitocin should be started low.
Question.
Yeah.
Yeah, I was just wondering, so because Pitocin has multi uses, how do you use it for a specific thing that you want to do? Like if you want to use it for induction, how would that be used differently so that it doesn't do the opposite? Because it kind of does different things. So I'm just having trouble understanding how you, is it the dose?
Yes. So when I say augmentation of labor, so maybe you need to slow down those contractions because you're planning to bring her in for a C-section. That would mean that you're titrating down the dose, right? That's
Oh, okay.
augmenting. Yeah. Is
Okay,
that kind
okay.
of where you're confused?
Yeah, that helps for sure.
Okay,
Thank
cool.
you.
Yeah. So that kind of ties into what I was just about to go into. So Pitocin should be started low and titrated to an optimal stage of contractions. So you're going to start Pitocin at a concentration of 0.5 to 2 milliunits per minute. And then you'll titrate that up every 15 minutes to an hour. And when I say you, I mean your nurse is primarily going to be doing this, but you could also advocate for yourself and you could be like, you know, could you show me how to do this? And ask her if she could walk you through doing it on the pump. That is totally okay. Whatever, you know, your nurse lets you do with her or him overseeing it, advocate for that because getting those skills in and doing that kinesthetic work is how you're going to best understand it conceptually, right? Then once they reach the optimal stage of their contractions and they're starting to dilate to a good point, the the concentration of pentosome will start to be titrated down. So this will be titrated down 1 to 2 milliunits per minute every 15 to 60 minutes as well. Once true labor has become present and they have reached at least that 5 to 6 centimeters dilation. It will also be stopped if they get to a point, you know, they're trying to induce and like something comes up, maybe the cord is being compressed or there's placental insufficiency, it may be stopped because they're planning to just rush her in for a cesarean because you don't want those contractions continuing and baby being, you know, tried to be pushed down through the birth canal and having that process continue. You're going to stop that process because you're going a different direction, right? Okay, there is a typo on this. It's actually, I copied and pasted this image. This is supposed to be late decelerations. Just big, I just caught this a minute ago. Just know this is not late acceleration. So fetal accelerations and decelerations. So fetal heart rate monitoring. Interventions if fetal heart rate drops and if late decelerations are noted on the fetal heart rate monitor, you're going to reposition mom. You're going to give oxygen therapy. You're going to turn off oxytocin. Pitocin, oxytocin, same thing. You're going to increase IV fluids to get that blood pressure up and help increase the heart rate. this is what the things that we do for late decelerations. If the heart rate's dropping and there is early or variable decelerations, the only thing we're really going to do is we're going to reposition mom and reassess. But if we go through all of these for late decels, none of them worked, we're going to be notifying healthcare provider and getting mom ready for that cesarean. What does a decrease in, this is a question for you guys, what does a decrease in variability of the fetal heart rate less than 30 minutes indicate?
Fetal sleep cycle.
You nailed it. Good job. Yeah, baby's resting. Our heart rates go down, circadian rhythms, right, when we sleep. Same with baby. Accelerations with fetal movement, or by contrast, are a positive sign. That means baby's being oxygenated. If we get up and we start walking around, after sitting here all day at our desk doing our work, you look at your Apple Watch, oh, my heart rate's going up, right? Yeah, same with baby. If he starts flipping around to reposition himself, whatever she is doing in there, that's totally normal to see those accelerations in good sign. Okay, I need a volunteer. This will go faster if we get volunteers. I'm gonna need 3. And it's okay, you guys. Like, when you put yourself out there and you get something incorrect, like, it's gonna help you learn it better. This is a safe space. We're learning here together.
I'll go for it.
Cool. All right, what do you think the baseline is of this fetal heart rate? Take your time.
175.
Perfect. How about, what do you think about the variability?
Moderate.
Say it again.
Moderate.
Close, it's minimal. So remember that minimal is like an amplitude of 5 BPM or less within that baseline, basically. Are there any accelerations?
No, I don't see any.
Good. No accelerations. How about decels? Decelerations.
Yes.
Yeah. What decelerations do you think are here?
That first one looks like it's starting with that first contraction, or that second contraction, so I'd want to say early.
So here's the thing. Early almost looks like it's mirrored. This is a contraction here. You guys see my mouse moving? Or no?
Yeah.
Yeah.
Okay. So this is a contraction here. This is a decel. If this is a contraction here and you're seeing a decel after it, what is that?
Late.
Late. How about the contractions? Are they regular or irregular?
Irregular.
They're regular.
Okay, that first little like double one's kind of throwing me off a bit.
Yeah, I know. And this is a good example of what you might see in real life for strips. Like this is like one contraction here because it didn't like fully return to the baseline, right? So yeah, they're pretty regular when you look at the strip itself overall. So this is a non-reassuring strip. It requires intervention because you're having those late decelerations, which are indicative of what? Do you guys remember with veal chop that we just went through?
Placenta insufficiency or problems.
Yeah. Yeah. So I actually didn't talk through veal chop. So that acronym, just get it in your mind. The veal going down one side, chop going down the other side. Veal coordinates with the cord compression, right? Each letter coordinates over like that way. So you can just picture that in your mind when you're thinking about those until you get them memorized, essentially. Great job. Who
I
was
have a
that?
quick
Sam?
question.
Was that Sam that just
That
spoke
was
through that? You did awesome. Good job. And then Soria, you have a question?
Yes, I had a quick question. So, if you're uncertain whether it's regular or irregular, would a confirming way to tell, could you like count the minutes in between each contraction? And let's say there were 2 to 3 minutes apart, then throughout the strip, that would be another way of telling whether it was regular for sure?
Yeah, you know what?
Okay.
Have your nurse sit down with you. This is the best thing you can do, and you guys can print out a strip, and then she'll show you where the minute marks are and how to be looking at this the best way. Don't get too worried for exam purposes. That's not going to be one of the questions. It's really going to be looking for those veal chop questions, right?
Okay, thank you.
So what I just went through was way more. And you can also, you'll get like booklets of strips. And if you take off the name, like what I did is I took them home and practiced with them because I'm a total nerd like that. But yeah, the best thing to do is maybe if you get a great nurse, just be like, hey, when you have a second, can we just like go through some fetal heart rate strips together? And that'll be super helpful for you. All right, next person. And you guys, like, if you volunteer yourself, I promise you it's beneficial for you.
Do I get a cookie if I volunteer to go next?
You get a virtual cookie.
I need cookies. If I need some, I need my blood sugar is low. I need cookies. Okay, cool. I'll go.
Well, then take a moment and
Did you
go.
just put your groceries away? Come on now. What's going on?
Do you need a minute?
No,
Are
I'm
you
just playing.
serious?
I'm playing around.
Okay.
I'm playing. Let me be serious with all these student nurses on the call. I don't need to be
All right.
revived. Okay,
How about
cool.
baseline for this step?
What's up?
Baseline.
So baseline, I would say, oh, I would say 145.
Perfect. How about variability?
I would say variability is moderate.
Yep. Good job. How about accelerations? Are there any accelerations?
I mean, if they are, they're pretty minimal. So I kind of want to say yes, but I'm not totally sure about that.
No, there's not.
Okay, because it would be a pretty significant spike if it was an
Yeah,
acceleration. Okay.
essentially that it's gonna be an amplitude of like I want to say 15.
Yeah, that's what was in the lecture, was 15 above baseline.
Okay, yeah, I'm just pulling from memory, you guys. But yeah, it's like you got to see that from the baseline, that either those accelerations or decelerations of that amount within
Okay.
a given minute.
Got it.
Yeah.
So no accelerations. Okay.
Yeah. How, or not within a minute. I think it's like within 20 minutes or something. How about, where was I?
You
S,
asked it. Oh.
decelerations?
Decelerations. Yeah, there are some decelerations.
No, there's
Oh.
neither accelerations or decelerations.
Okay.
And then how about her contractions? What do you think about mom's contractions?
They're pretty irregular.
They're irregular, yeah.
Yeah.
Actually, this is actually more indicative of occasional contractions rather than irregular.
Oh, okay.
Because there's actually only one, right?
Yeah.
This is just noise. These aren't contractions.
Oh.
This is a contraction. Yeah. This is kind of like her baseline right about here. This is a contraction. Okay, so this strip is overall reassuring. It's not reactive though, but if we had looked at like a 20-minute period of this fetal heart rate monitoring, we would probably see that it is reactive.
Okay, so that brings up a question for me, and maybe it's in my notes and I just haven't found it, but could you kind of go over reactive versus non-reactive?
It's just what I just said. So reactive is, you're going to have 2 or more of accelerations within like that 20-minute period. So if we looked at this over a 20-minute period of fetal heart rate monitoring, we would likely see that it is reactive.
So there has to be
basically,
accelerations present for it to be
else that's, like,
considered. Oh,
concerning to us with this strip.
okay. So let me just to clarify. Sorry, because I think I was talking over you by mistake. There has to be accelerations present in order for it to be considered reactive. Is that right?
Yes. Yes.
Perfect. Thank you.
Yep. And what else should I say? Don't worry too much about like reactive versus non-reactive. One, it's not going to be on the exam. And 2, when that was something that I was super confused about at first. And I asked my nurse and they're like, don't worry about that. And I don't think that they even like really monitor it or something with her response. They document those other things that we just went through. I think that they document a little bit more from my memory on contraction. But they actually don't document anything on reactivity. So just a little piece of advice for you guys. Don't worry too much about that. Okay, next person.
Really
One
quick,
more.
would you mind going over the little rule of how you differentiate between the minimal and moderate variability?
So that is just knowing the beats per minute basically from baseline, and minimal to absent is less than 5. Moderate is 6 to 25, and then marked is going to be 25 or greater from baseline.
Thank you.
Cool? Yeah. One more person, you guys. Sorry, yeah. Take a stab at it. Please. If you're really not comfortable, it's okay though.
I could go.
Okay, thank you. All right, how about baseline?
145.
Yes, perfect. How about the variability?
Um, would it be, is it absent?
Yeah, yep. So accelerations or decelerations?
Neither.
How about contractions?
Occasional.
Yes. And what do you think about this strip overall?
Intervention is needed.
Yeah,
Non-reassuring.
it is not reassuring. Minimal or absent baseline variability is the most concerning for fetal heart rate monitoring. Just know that. It's not a good sign. You're going to be starting to do those interventions with mom, right? Yeah. Good job. You nailed that. Okay, fetal positions. So there's abnormal positions, and then there's normal presentation. What is normal presentation called, you guys? You guys should totally
Vertex
know
or
this.
vertex
I think
or
it's like off.
No,
Oh, sorry,
the presentation. Yeah, Sam, you had it.
the occiput anterior or something like that.
Occiput anterior, so the
Yeah.
occiput of the skull, right? The occipital portion. That's what's going to be presenting to the anterior side of mom, right? So baby's going to be coming out like this. This is the normal, best way for baby to be coming down through the birth canal. And then this position is occiput posterior. Now, this is technically an abnormal position. This is how I was born. It's not optimal, but it's not as dangerous as these presentations up here. So these can definitely lead to more problematic issues. We try to, get baby presented in a different way if possible. That may be the physician going up in there and trying to see if she could flip baby or do whatever you need to do. Leopold's maneuvers might also be used to determine the fetal lie presentation and engagement. And sometimes they may manipulate on the outside of the belly to try to get baby flipped as well. With the occiput posterior, this is more difficult for mom to get baby to go down through the birth canal, and it could, there was one student in my cohort, actually, she delivered her baby this way, and she ended up injuring her tailbone. I forget if she said it broke or what it was, but this is not an optimal way for baby to be coming down through birth canal. This is the best way, occiput anterior. Good job. All right, delivery. Is it time to push? So knowing when time to push, dilation happens between 0 to 10 centimeters dilated. Naturally, it's naturally closed, and then it dilates and opens in preparation for delivery. Effacement is 0 to 100%, and there's that thinning of the cervix. Presenting station is the level of the presenting part of the baby's head here, relative to the stations, which are above or below the ischial spine. So you have 0, and then going further up into the birth canal uterus is going to be -1, -2, -3. You want to get baby down into the positives before you're getting to that point where it's okay to start pushing. Like, even if they are like fully effaced, they're 10 centimeters dilated, you're going to want them to be descending down. That's going to be the biggest thing, because it's just not going to be good. I had a mom that was actually, baby was still at like a 0 station, but she was getting to the point where she was, her dilation was really starting to open up. Her effacement was starting to reach full percentage, but if they're not dropping down, like, it's not a good thing to try to start pushing. So you want them down at a good station. You want them getting to close to 10 centimeters dilated and 100% effacement before they start pushing. All right, delivery time. So transition to labor. This is like the most exciting period. And I really hope that each and every one of you gets an opportunity to be part of this, to see it. So if mom states she has a strong urge to defecate, what's the first thing you want to do? That's right here. We're going to be doing a vaginal exam, because maybe baby's starting to descend down, and it's time to like get doc in there, midwife, whoever's delivering, and it could be time. Yeah, baby could be starting to come out. So the anus or rectum starts to protrude as baby is descending through the birth canal, and this is indicative of birth being imminent. Transitional labor happens right when she is saying that she can't do it anymore, like she's tapping out, like they'll say, I can't do this, I can't do this. This is the time for you to champion mom and be like, you can do this. Tell her that you are nearly there. It's time to push. This is the most overwhelming time for mom, and during the laboring process, basically. When it's also the most painful, I believe. I don't know if that's probably, like, it probably varies person to person to say that's most painful. Some women may think that the laboring process before that was more painful. When fully effaced, dilated, and baby is in the optimal presenting station, it's time for mom to push. Okay, so that we got through full information for exam. Now we're going to do some practice questions. And we're gonna put them up in the chat today. I'm not gonna go through the polling, if that's okay with you guys. Okay. A 30-year-old female is 25 weeks pregnant with twins. She has 5 living children, 4 of the 5 children were born at 39 weeks gestation, and 1 child was born at 27 weeks gestation. 2 years ago, she had a miscarriage at 10 weeks gestation. Okay. GTPAL. Give you guys like 1 or 2 minutes to do this. It's kind of like a little puzzle. Okay, so we have Isha saying G7, T4, P1, A1, L5. Deb agrees with Isha or Sam. Any others? Okay, so it's 7 for G, 4 for T term, 1 preterm, 1 abortion, and 5 living. And yes, the twins count as 1, but it's still 7 in total. Good job. The nurse should realize that the most common and potentially harmful maternal complication of epidural anesthesia is A, severe postpartum headache, B, limited perception of bladder fullness, or C, increase in respiratory rate, D, hypotension. We already got some coming in. Most common and potentially harmful maternal complication of epidural. We got some D's, B's. Looks like it's crossed between D and B. It's hypotension, right? Think about what the epidural causes. Headache is not a side effect since the spinal fluid is not disturbed by anesthetic because it would be with a low spinal saddle block anesthetic. Limited perception of bladder fullness is an effect of epidural anesthesia, but is not the most harmful. Respiratory depression is a potentially serious complication. Epidural anesthesia can lead to vasodilation and a drop of blood pressure that could interfere with adequate placental perfusion. The woman must be well hydrated before and during epidural anesthesia to prevent this problem and maintain adequate blood pressure. So that one ticks off the two boxes of most common and most serious. Does that make sense for those who answered B? So yes, B could be a problem. Even the increased respiratory rate could be a problem, but that one's not common. So it's checking off those two boxes. Yeah.
It makes sense, but I think the reason why I actually put it is because all I've been hearing this entire time in this class is like postpartum hemorrhage is like the most dangerous, condition that a mom could be in after giving birth, and having that not being able to tell that their bladder is full is like, oh, this could cause them to bleed more. So that was the reason why I said that. But yeah, that
Yeah,
makes sense.
epidurals after mom delivers, epidurals start like their effects start right away. Um, the the whole idea with like the risk with postpartum hemorrhage due to like them not being able to feel that distended bladder, remember it's because they're edematous and they're not aware of like the fluid like pressure changes basically that are happening. It's not really to do with the epidural at that point anymore, not so much. That makes sense?
I have another quick question. Is that hypotension the result of them being in the epidural space, or is it the result of the drugs they're pushing?
The hypotension could be a result as from the epidural itself.
Thank you.
It's a potential like side effect of it. So things we do, interventions to make sure that that does not become a complication. Again, as we keep mom well hydrated and we monitor that blood pressure carefully. Good job, guys. Okay, when managing the care of a woman in the second stage of labor, the nurse uses various measures to enhance the progress of fetal descent. These measures include A, encouraging the woman to try various upright positions, including squatting and standing. B, telling the woman to start pushing as soon as her cervix is fully dilated. C, continuing an epidural anesthetic so that pain is reduced and the woman can relax. D, coaching the woman to use sustained 10 to 15 second closed glottis bearing down efforts with each contraction. So second stage of labor. And this is like not one that's she's not gonna ask too many questions on like the different stages of labor. So don't, because I didn't focus on that in my review. This is just like a good NCLEX style question for you guys. Got some A's. Good job, guys. So encouraging the woman to try various upright positions, including squatting and standing. Upright positions and squatting may enhance the progress of fetal descent. They also, they have different things that they may use for equipment to try to get baby to descend. There's like the peanut ball. There's different ways. Many factors dictate when a woman will begin pushing. Complete cervical dilation is necessary, but is not the only one factor. Remember, we went through effacement, the presenting station. It's not the only factor that we use, right? Complete cervical death, yeah. If the fetal head is still in a higher pelvic station, the physician or midwife may allow the woman to labor down, allowing more time for the fetal descent, thereby reducing the amount of pushing needed. If she is able, the epidural may mask the sensations and muscle control needed for the woman to push effectively. And then closed glottic breathing may trigger the Valsalva maneuver, which increases intrathoracic and cardiovascular pressure, reducing cardiac output and inhibiting perfusion of the uterus and placenta. So we definitely don't want to do that. In addition, holding the breath for longer than 5 to 7 seconds diminishes the perfusion of oxygen across placenta and results in fetal hypoxia. Whatever is happening to mom is happening to baby. Think about it that way. But I know you guys aren't going to pick that one. Good job. Okay. A woman who is 39 weeks pregnant expresses fear about her impending labor and how she will manage. The nurse's best response is A, don't worry, you'll be fine. B, it's normal to be anxious about labor. Let's discuss what makes you afraid. C, labor is scary to think about, but the actual experience isn't. D, you may have an epidural, you won't feel anything. Good job, guys. Yeah. Yeah. I don't think I need to read the rationale. That was kind of pretty straightforward, just a little easier question for you guys. Vaginal examinations should be performed by the nurse under which of these circumstances? This is a select all that apply question. So there's A, an admission to the hospital at the start of labor. B, when accelerations of the fetal heart rate are noted. C, on maternal perception of perineal pressure or the urge to bear down. D, when membranes rupture. E, when bright red bleeding is observed. Select the all that apply. A and C. B, C, D. Good job. Good job, Deb, and whoever else answered. Yeah, ACD. So an admission to the hospital at the start of labor, when maternal perception of that perineal pressure, if they're saying to you that they have the urge to push, you're going to be, inspecting that area, and when membranes rupture. Vaginal examination should be performed when the woman is admitted to the hospital or birthing center at the start of labor. An accelerated heart rate is a positive sign. Variable decelerations, however, merit a vaginal examination. When the woman perceives a perineal pressure or the urge to bear down, it is an appropriate time to perform a vaginal examination. After the rupture of membranes, a vaginal examination should be performed. The nurse must be aware that there is an increased risk of prolapse cord immediately after the rupture of membranes. And examinations are never to be done by the nurse if vaginal bleeding is present, since the bleeding could be a sign of placental previa. We will get to that if you guys haven't already gotten to that. And a vaginal examination could result in further separation of a low-lying placenta. Excellent job. All right, guys, that's it. Good luck. I'm going to stop the recording and help you with any questions.